So this would be the progress of diagnostic imaging in the past year. So starting from the origin of CT, MRI, the introduction of MIBG, 1982, pentatriotide, as we saw before, 1992, introduction of carbon-11, HTP, hydroxytryptophan, PET, in Uppsala in 1993, and also in Groningen, gallium peptide PET in 2001, F-DOPA 2002, radiologic imaging, diffusion-weighted imaging, MRI 2008 in NETS. The rediscovery of FDG PET of neuroendocrine tumors in 2009 with the prognostic significance, not the diagnostic significance. The discovery and the introduction in clinical trials of somatostatin receptor antagonists, which have a better uptake in tumors. The introduction of a new way to do PET for neuroendocrine tumors with DOTATATE labeled with copper, which lasts longer and allows for later imaging. And the fusion recently of DWI imaging with MRI and gallium PET. And this is the slide I showed before, so I would skip it. Regarding the, sorry, I wanted to go back. Let me go. So this is the slide I showed before on the neuroendocrine tumor of the pancreas treated with yttrium-DOTATOC. This is another neuroendocrine tumor of the pancreas imaged with gallium-DOTATOC. You can see here the lesion in the uncinate process of the pancreas together with liver metastasis, diffuse liver metastasis, and lymph node metastasis here, one right below the pancreatic lesion. You can see here a simultaneous, very close in vicinity image with imaging with gallium, DOTATOC, and FDG in the same patient with this very big lesion involving the body and tail of the pancreas. You can see the distribution of uptake, so the distribution of increased metabolism in this lesion, and the distribution of somatostatin receptors. And so this has prognostic significance because it has been demonstrated that patients with FDG uptake have a shorter progression-free survival. So whatever therapy they're doing, it lasts a little bit shorter than in other patients where the imaging is negative. Then we have another tracer, which is F-DOPA, which is taken up by neuroendocrine cells and is a measure of neuroendocrine specific metabolism. And despite the fact that fluorodopa has no therapeutic counterparts as opposed to gallium peptides or octreoscan, it is probably in a method that will be used in the future to measure the response to treatments, because it measures the metabolism of the neuroendocrine tumor cell, and it may be used in those cases where somatostatin receptor imaging is negative. There are not many of these cases, but indeed this is as they call a problem-solving tool. And this is the uptake. You can see in this big lesion in the head of the pancreas. You can see here the three-dimension image, the MIP, maximum intensity projection image, and this is the correspondent slice, axial slice at F-DOPA. As I mentioned before, another tracer of neuroendocrine metabolism is hydroxytryptophan. You can see here in this pancreatic tumor, which has spread to the bone, liver, and lymph nodes. Actually, this tracer also is considered a problem-solving tool in cases where, especially in cases where the imaging with somatostatin receptor analogs is negative. However, this is more complicated because the radiotracer is carbon-11, requires an on-site cyclotron, and it's not available in all centers. Actually, in Europe, there are only 2 centers active with this kind of imaging. And this is an example of the antagonists, and this is directly labeled with lutetium. So this is what we talked about, lutetium dotatate. This is the uptake in lymph node and liver lesions with lutetium dotatate. This is the dosimetry showing a certain dose to the liver and to the lymph nodes. But once we use this new compound named DOTA-JR11, which is an antagonist of the receptor, so a new class of somatostatin receptor peptides, you can see that the doses are at least twice as high.
I think in the interest of time, we have to keep this close. But at the end of this lecture, we know that we are living in the exciting time and moment because we are in the midst of molecular revolution. So hopefully the new technologies will allow us to progress further and make this disease more manageable and with better outcome.
Thank you both for your excellent presentations today. We have a small gift for each of you as a token of our appreciation for your participation today. We can just invite Dr. Liao to present it to both Dr. Milan and also to Dr. Bodei. Thank you very much. Well, that ends our program for this evening. Thank you all for joining us this evening. And we have a small little snack stand outside, so if you can join us for a little bites, that would be great. Thank you. Thank you very much.
Well, let me just in closing say how grateful I am to both for arranging this and inviting us here today. And thank you very much for your very nice words, and very grateful for your very provocative and thoughtful questions, and appreciate being here. It's a very thoughtful place to come to.